Hi, everyone. I am Justice Talbot. I'm going to be your instructor for this evening. I am the program director at Caldwell Community College and Technical Institute, which is in Hudson, North Carolina. And I have been a rad tech for 10 years now, and I've been teaching for a little over 5. So I love what I do, and I'm really excited to be here. And I'm going to answer some of your questions tonight. So we've got some questions that were sent in by students, so I'm going to start with those. All right, so the first question comes from Julie. She asks, since fluoroscopy provides real-time imaging using continuous or pulsed X-ray beams, how do we balance maintaining adequate image quality while minimizing patient radiation dose, especially during longer procedures? So I think my best advice for that is going to be to follow your doctor's orders. Your patients that are getting fluoroscopy exams or that are getting fluorid in the OR, they're just going to get more dose. That's just kind of the nature of the beast. But we want to make sure that we're not exposing unless the doctor has told us to. So that's going to be the biggest thing that's going to help minimize patient dose. The other thing that I can tell you is try to maneuver and position your C-arm as much as you can before you actually start taking the exposures. That way you're not taking an exposure and then realizing you're not in the right spot and then having to move and then expose again and then move and then expose. So things like in the OR, putting tape on the floor or making notes of angles that you're at, things like that will help you so that you don't have to do a lot of unnecessary exposing just to get in the right position. Another important thing to remember too is also swapping images, especially in the OR. So if you're at an AP and then you want to go to a lateral, make sure that you're swapping the last image that you took over to the hold screen before you switch projections. That way the doctor has that to reference, and then he's not going to make you go back and take an additional image. So all of those things combined is going to help to cut down on the patient dose, and also to the dose to all the people in the room too, because it's also our job to make sure that we're not exposing ourselves and our coworkers to unnecessary radiation. And then when you are taking images, when the doctor does tell you to take a shot or an X-ray or whatever verbiage they use, don't hold the button down unless they ask you to go live. So just a quick press, that's all you need. Remember that X-rays are happening in a millisecond. So just super quick shot and then wait. Keep your eye on the doctor, wait until they tell you to take the next one. So all of those things together should help to keep the radiation dose pretty low for you. All right. She had a second part to that question. It said, additionally, could you explain how factors like KVP, MA, and exposure time differ in fluoroscopy compared to standard radiographic imaging, given their role in controlling beam quantity and quality? So this is a good question, comparing the two. So remember that when we're talking about regular radiography, we're taking a still image versus fluoro, which is a live video. So when we take a still image for radiography, we want something that's going to be really high quality, lots of detail, really good contrast. Versus when we're doing fluoroscopy, we're not necessarily going for the end result image. We're just trying to see things happening in live real time. So with regular radiography, we want to have a higher MA because that's going to help us get more photons on the image receptor, not have grainy appearance, that quantum model. And it's going to happen in a very short amount of time because we want to reduce motion because we don't want blur on our still images. And then also we're choosing our KVP specifically for the contrast that we want. So higher KVP, lower contrast, lower KVP, higher contrast. So with fluoroscopy, we're basically doing the opposite of all those things. So we're actually going to lower the MA so that in turn, we can increase our time. We can't have high MA and high time or else we're going to cause too much heat in the tube. So we can't have that. So we drop the MA, we can increase our time, which allows the doctor to go into live video fluoro. And then KVP is actually going to be controlled by the ABC, which is your automatic brightness control. So the machine's going to be automatically adjusting KVP to maintain a certain amount of brightness on the screen. So it's a little bit different than us trying to control contrast in a static image. So those are the main differences between regular radiography and your fluoroscopy. All right, that's a good question. Next question. This is from Marcos. This says, when doing ribs, what are the key anatomical landmarks we should always verify to ensure proper positioning? Okay, everybody loves ribs. So I'm going to talk about both scenarios, your AP, PA, or obliques. So when you're doing your AP and PA, one thing you want to check for that a lot of people miss is making sure that you get the entire first rib. So you have to remember that that first rib, that small little curved one, goes up a little bit above the clavicle before it curves back down. So you've got to check to make sure that you have that in there. So don't cut that off. Then you're going to check your lower ribs. If you got all of the ribs in one image, look at that 12th rib because you have to remember that it does project very inferiorly. So you don't want to cut off the bottom of that. Then you're going to look at the spinous processes going down the vertebrae to make sure that you're not rotated. Now, if you did not get all of your ribs in one image, you're going to have to do a lower AP or PA ribs. Then you're going to want to make sure that you have some overlap. So let's say you got T1 through T10 on your first image, you're going to want to make sure that you get at least T10 through L1 on the second part of the image to make sure that you've got a little bit of overlap there. Now, when you're talking about obliques, we want to make sure that you have spine visible on your obliques. So you have to be careful where you're centering the patient and where you're collimating to make sure that you haven't cut off the connection where the spine and the rib is actually meeting. So make sure that you actually have spine for every single rib. So that's important too. Okay. And then also you want to look on the anterior part of the body and make sure that you didn't cut off the anterior part of the ribs right where it curves. So if we're not careful with our collimation, it's very easy to collimate too tightly and then cut that anatomy off. All right, and then the second part of this question said, also, how does the position of structures like the diaphragm and ribs help us determine if the image was taken during full inspiration? I get confused on that. Okay, so let's clarify that. So when you take a deep breath in, the diaphragm lowers. So you have to think about it. The diaphragm is coming down to allow space for all of that air to come into the lungs. So our diaphragm is going to drop. So we want to count how many ribs we have above the diaphragm. So if we had a good full inspiration, we should see typically 8 to 10 ribs above the level of the diaphragm. If something was taken on expiration or the patient was just holding their breath and not taking a big breath, you'll see generally less than 8 above the diaphragm. So the parameters there are very similar to what we look for in a PA chest. All right, that's a good question. Next one. This is from Mandy. Mandy asks, this is a patient care question. How do we adapt our approach when working with patients who are anxious, in pain, or unable to follow instructions effectively? Okay, Mandy, this is a loaded question I could probably talk about for like 3 hours straight, but I'm going to try to give you some tips for each of these different types of patients, okay? The first thing I'm going to tell you is what I tell all of my students when they very first start out the program, and the first thing that they're learning is their patient care, and they're learning about patient interactions. And I tell them the same thing every year. As soon as you get a patient, the first thing you have to start doing is assessing them. From the moment you put eyes on them, from the moment you start talking to them, you are assessing your patient. So I've got a piece of paper that tells me their name, their date of birth, their condition, what their exam is, right? So we've got some statistical information. But then I want to actually put my eyeballs on them and start talking to them. And I want to see how they're responding, if they're coherent, are they answering my questions? Do they seem like they have altered mental status? Are they nervous? Are they under the influence of something? I'm also assessing these patients so that I can tell if their condition changes while they're with me. So when you start talking about medical emergencies, right? How am I going to know if my patient is suddenly going into shock or having a heart attack or a stroke if I don't know what baseline is, right? So I want to be assessing them from the moment I get them all throughout my time with them to know if anything has changed. So when I start talking to my patient and I'm asking them questions and telling them what I'm going to be doing in this particular exam, right? Explaining I'm going to need you to lay on the table, or do you feel okay standing for a couple of images, things like that. I'm gauging their response and their answers and to see how they are. Okay. So if you've got a patient that's anxious or nervous, right? The best thing to do is talk them through the exam, right? Don't just be quiet and ignore them or act like, I don't want to say too much or it's going to stress them out, right? Talk to them. Okay. The most often that we see this is with kids, right? So kids are usually nervous when they come in because they've probably never had an x-ray before. Hospitals are scary. Maybe they got hurt, right? Or the last time they went to the doctors, they got a shot, right? So that kids can come in usually pretty anxious, pretty nervous. And we got to talk them through the exam, right? Tell them who you are, what you're going to do. Use simple language, right? Don't tell them I'm taking an x-ray. Just say, I'm going to take some pictures of your belly, right? Mom says your belly hurts. We're going to take some pictures so the doctors can make you feel better. Very simple language, very calm, right? Get down to their level. Let them know everything you're going to do before you do it. Tell them I'm going to move my camera. This big thing hanging from the ceiling is just a big camera, right? I always tell the kids it's like when mom takes a picture of you with her cell phone. This is like a really big cell phone, and I'm just going to take some pictures of your belly or your chest or your arm or whatever it is, right? And then just let them know as you're doing things. You're going to see a light turn on. I'm going to go push a button to take the picture, and you're going to hold your breath like when you go swimming. Okay. Kids are going to respond to the way that we act, so we want to keep them calm. So you have to act calm. And the same goes for adults too. They're going to react the same way you react, right? So just calm, simple language, very matter of fact talking with them. Now, when you have a patient who's in pain, reassure them that you are going to be careful. I'm going to go as quickly as I can, right? When you have to tell a patient whose back is hurting because they fell off of a ladder that they now have to lay on your hard metal table, that's not really appealing to them, right? So let them know, yes, I need you to lay on this table. It's going to be really uncomfortable, but I'm going to go as fast as I can and get you off of this table, right? That's what they want to hear. They want to hear you're going to get me off this table, not you're going to leave me here for the next 2 hours. Okay. Also let them know I'm not going to touch your injury if I don't have to. So if you've got someone with a broken arm or an open wound or something like that, I'm not going to touch you. I'm going to let you move your body parts, right? Because they might be really nervous about, don't move my arm, it's going to hurt really bad, or, don't touch that. So just reassuring them that you care, right? That they're in pain, that you're being sympathetic. Um, Letting them do as much of the moving and rotating and stuff as you can, and only touching them if you really absolutely have to. Okay. If you have to touch the patient and they are in pain, please let them know beforehand. I'm going to press on your hip. I just need to find my location, right? Or I'm going to help you turn your leg. Is it okay if I touch your knee? But let them know ahead of time. Okay. And they're usually going to be much more cooperative if you do that rather than just grabbing things and trying to manipulate them. So just again, talk to your patients. Okay. And then if you do have to move their body parts, especially ones that are injured, just do it slowly. Be confident when you're holding their body parts. Make sure you're supporting them. If you have to move a limb that's broken, make sure you're supporting at both ends of the joints. If you have to lift, only lift as high as you really need to put a board under, things like that. That's going to make the patients feel a lot more comfortable with you. And they're going to feel like, okay, this person has done this before. They know what they're doing. They actually care that I'm in pain. They're not trying to hurt me. And your patients will be a lot more cooperative. Now, the other one is those patients that can't or don't want to follow instructions. So a lot of patients that we get that are this particular issue are altered mental status. So a lot of patients are going to come in with Alzheimer's or some kind of dementia. They can be very, very challenging because you're looking at them like you're an adult. You should be able to follow instructions if I tell you to sit still and hold your breath. And they are doing everything but the thing that you have asked them to do. But we have to remember with those patients that they don't know what they're doing, right? Don't take it personally. Don't get frustrated. They're not trying to annoy you. They're not trying to make your job more difficult. they really have no idea what is going on. And usually by the time they've ended up in the hospital, they're really having an episode. Like, they really don't know what is going on, right? So you just telling them to hold still and hold their breath, that is not the words that they are hearing, right? So we just have to do our best to move as quickly as possible and to get the best images that you can. They are probably not going to be your best images, right? You're going to have to try to catch inspiration if you're doing a chest x-ray, right? You're going to have to try and time it and just catch it. You're going to have to lower time as much as you can to try and get those body parts because they're not going to hold still, right? So it's definitely going to be some of your challenging patients. I would also strongly suggest, once you're graduated and a working tech, if you have patients like that, is to get a partner. Grab one of your coworkers and say, "Hey, can you come help me with this?" Because it's going to be a challenging case, right? So you may need someone to help you move them, reposition things, somebody to, help set up the machine and get on the rotor while you run out of the room real quick so you can grab that image before they move. But definitely, you know, get a friend to help you with those ones because they can be very difficult. But that was a good question because I know that is something that, as a student, especially if you've never worked in healthcare before, dealing with difficult patients can be a whole new world for you. All right, we'll go on to the next question. All right, so this is from Rick. Rick says, "Can you please explain the difference between Compton scatter and coherent scatter? What effect do they have on the image and patient dose?" Okay, so Compton scatter is going to happen a lot, right? Compton scatter is the biggest source of our occupational dose, and it's also going to be the biggest source of scatter on our image. Okay, so Compton scatter, we are actually, a photon is coming in and knocking out an electron from orbit. So we've created a hole. The atom is now unstable. We don't like that hole. We have to fill that. So we're going to have a characteristic cascade. So an electron from another orbital shell is going to move into that hole to fill it. In the process of that movement, it's going to give off a photon. So with Compton scatter, what's happening is we are actually creating new radiation inside the patient's body. So we call that radiation secondary radiation because it's not made in the tube. It's actually made in the patient. Okay. So if we're creating new radiation inside the patient's body, that is definitely increasing patient dose, hands down. And because we've got additional photons now, they could potentially land on our image receptor. And then we also have the original photons that came in and bounced off of things that are now scattered. So that additional scatter could land on our image receptor. And then the effect it's going to have on the image is you're going to end up with that gray fog everywhere. Now, that's one big reason we don't like scatters, because we get that gray fog. That fog can obscure detail. So we might not be able to see things that technically the detail's there, but we can't see it. The other problem is those scattered photons are coming from somewhere other than the actual anatomy that they were headed towards. So we may be getting misinformation. So we're not really seeing accurate information of what's in the patient's body. So this is why we use grids to clean up scatter, because it serves no purpose to us, right? It doesn't help. We get fog and we get misinformation. Now, scatter is inevitable. We can't avoid it. We can do things to minimize it, but it's always going to exist in the patient's body. So it's always going to increase patient dose a little bit, and it's always going to cause some fog on the image. So grids will help clean up the fog, but they're not going to help reduce the scatter in the patient. So to help reduce scatter in the patient and limit their dose, we want to make sure that we're collimating properly, and we want to make sure that we're using correct techniques. So the higher your KVP gets, the more scatter you're going to create. So we don't want to use excessive KVP if we don't need to. So make sure that you're using techniques that are appropriate for your exam, and that will help. Now, the other part of the question asked about coherent scatter. So coherent only happens at very low energy levels. So we're talking 10 kVp or less. So there's not going to be a lot of that happening in the patient's body, but it will happen. We can't avoid it. So with coherent scatter, the X-ray photon's coming in, but it's not knocking an electron out. So we're not creating a hole. Because this is such a low energy photon, it's coming in and it's basically just going to pass through the atom. Because remember, an atom is mostly empty space. It's going to pass through the atom, and then it's just going to cause the entire atom to vibrate a little bit. And then that same amount of energy is just going to exit the other side of the atom. So we didn't create a hole. We didn't knock anything out. We're not going to cause a characteristic cascade or secondary radiation or anything like that. So it's just going to come in, make the whole atom vibrate a little bit, and then off it goes. Now, coherent scatter, yes, that photon could land on the image receptor. That is possible. There won't be a lot of those particular photons because in our X-ray beam, a lot of them are not going to be that low energy. So it could have a very tiny contribution to scatter. As far as patient dose, most likely most of those photons will end up getting absorbed in the patient's body just because it's so low energy. So something with 10 kVp or less just isn't going to have the energy to really pass through the patient's body very successfully or cause any other interactions. So eventually it's just going to end up getting absorbed. But luckily there's so few of them that that's not going to be a huge contributing factor to patient dose. All right, hopefully that helps. All right, next question. This one comes from Jamie. Can you explain what somatic, stochastic, and deterministic effects are? How can I remember this better? Okay, so hopefully I can give you a little trick to help you remember this. So somatic is talking about what affects the body of the person exposed. So we're generally talking about the patient when we're talking about these scenarios. So you're thinking about what's going to affect the body of my patient. Okay. These are going to be things that happen specifically to the individual and not things that would be passed on to their offspring. Okay. So these are going to be things that just happen to them individually, not things that are going to continue generationally. Okay. So things like erythema, so you get the redness of the skin, right? That's happening to the patient right now. Okay. Hair loss. Okay. Cataracts, cancer. Okay. So when you hear the word somatic, think of the first part of it, which is soma, and think self. That's what's happening to myself, right, as the patient. Okay. Stochastic is about chance-based. It's random. Okay. There's no threshold dose. Okay. The more dose, the higher the probability something happens. Okay. So when you hear the word stochastic, think statistic. Okay. They kind of sound alike, right? So we're talking about there just being a statistical chance. Okay. So you can think of it kind of like playing the lottery. Okay. If you buy more tickets, right, that's more dose for the patient. You have a better chance of winning, which in the patient's case is not really winning because they're probably getting cancer, right? But they have a better chance of getting that thing. But the prize itself, the jackpot or the severity of the cancer, doesn't change. Okay. So it's a random game of chance when you hear stochastic. Okay. Then we have deterministic. So this is predictable damage. Okay. It has a threshold. Once that threshold's passed, you know that you're going to get that effect, right? It's predictable. We say you hit this, you get that. Okay. So the severity increases with the dose. So you hit that threshold and XYZ happens. But as you continue to go above that threshold, that severity gets worse. Okay. So examples for this: skin burns, radiation sickness, cataracts, sterility. Okay. So when you hear the word deterministic, think definite. Definite kind of sounds like deterministic. It's determined. Okay. It's kind of like if you were to touch a hot stove, once it's hot enough, you get burned. But if the stove is up even more, you'd get burned worse, right? So you turn the temperature up and the burn gets significantly worse. But if the stove is off, nothing happens until you hit the threshold, which is turning it on and it actually getting hot. So I hope that helps you remember it a little bit better. All right, next one. This question came from Tommy. He says, I struggle with my scapular Y views. They always come out rotated. Are there any tricks you can share? Okay. So scap Ys are challenging. You are not alone on this, right? A lot of people struggle with this, even well beyond being a student. Okay. Um, Honestly, you just got to get in there and you got to feel the patient. Okay. So put your hand on their back so that your palm is touching the back of their scapula. And then you want your fingers to be pointed at the board. And then you rotate your patient however you need to until your fingers are perpendicular to the board. Okay. That now means that the body of the scapula is going to be perpendicular to the board. Okay. So, of course, the textbook says, you rotate X amount of degrees, but every patient's going to be a little bit different. And the placement of the scapula is going to depend on how rotated your shoulders are forward. So, if somebody comes in and they're really kyphotic and their shoulders are really rounded forward, their scapula is already severely rotated forward. So, you're going to have to adjust the body part until you get your hand perpendicular, right? Versus having somebody who comes in with really good posture and their back is super straight and their scapulas are almost perfectly straight across their back. It's going to be different positioning. So with that, you can't just go in and go, well, the book says this many degrees, so that's what I'm going to do. You got to get in there and feel the scapula. Okay. If you have a hard time feeling the scapula, you want to go on the medial border and really feel for that edge and kind of dig your fingers in there a little and find it. And I just tell the patients, I'm just going to get in here and kind of feel for your shoulder blade and then get in there and find it. And then put your palm on it and rotate them until you're perpendicular. Okay. The other thing is when I'm doing a scap Y specifically for a shoulder exam, the whole purpose of the scap Y in a shoulder is to check for dislocation. So we want to see if it's anterior or posterior dislocation. So make sure that the humerus is back and lined up with that body of the scapula. So you don't want to have their arm forward because that's also going to change the position of the scapula. So just make sure that the humerus is going right down the side of the body. So hopefully that helps you. Good luck. All right, next question. This comes from Steve. He says, I sometimes feel like I have imposter syndrome. How can I work on building my confidence when I'm in the clinical setting? So, Steve, the best thing that you have to do is remember that you're not an imposter, you're a student, right? You are there to learn. Nobody expects you to know it all. You're not officially a tech yet, so it's okay. Okay? Everybody, literally everybody had to start as a student. Even your teachers, even the techs that have been doing it for 30 years, they were all a day one freshman student at some point. Okay? Nobody becomes a tech without being a student first. So just remember that we've all been through it. You have to go through it to become a tech, right? And people know you're a student. So they don't expect you to walk into clinicals and just know all the answers and know how to do everything when you've never done it before, right? So sometimes as a student, we put unrealistic expectations on ourselves that other people have not put on us. And I know specifically with rad tech students that we are perfectionists, we are go-getters, we are hard workers, we want to do well, right? You don't get into this program if you're not that kind of person, right? So you go to clinicals with those same expectations for yourself, okay? And I see it every single year when I send freshmen to clinicals for the very first time. And they go in there just thinking they're going to run the department day one. And that is not what happens, right? So you've got to remember, just go in, do the best you can, and learn every single day. That is what you are there for. Nobody is expecting you to come in and run the department. They are expecting you to come in and to learn. So be open, take advice, ask good questions, show initiative. People are going to be blown away if you can do those things. And the techs will be happier to teach you and tell you all of their little tricks when you go into clinicals with that mentality. And you're going to feel a lot better about your time there. Okay, so just remember, you're a student. It's okay. You're there to learn, and everybody knows that you're there to learn. So you have to be more realistic with your expectations because other people are not expecting you to walk in and be a tech when you are a student. Okay, hope that helps you. All right, next question. This one is from Randy. Says, I understand that quantum noise decreases when IR exposure increases by increasing KVP or mass. But how do we decide whether to adjust KVP versus mass in a clinical situation without negatively affecting image contrast? Okay, so Randy, what you're describing, quantum noise, is when we have that grainy appearance on the image. So what it means is you don't have enough exposure. Exposure meaning photons. The only way to correct quantum model is to increase mass. It is literally the only way. You can increase KVP all day long. It will not correct for quantum model. And I do this experiment in the lab with my students every year just to prove the point. And we increase KVP again and again and again, and our image is still grainy. Okay. You have to increase your mass. So if that's the image issue that you're having is quantum noise and it's grainy, the answer will always be increased mass. Okay. Now, how are you going to know how much you need to increase? That's when you need to look at your EI or DI numbers, so your exposure index or your deviation index. Okay. So we can't just look at an image with our eyeballs and say, oh, well, it's grainy and I'm going to change it this much. We have to remember that because we live in a digital world and we're using computers to take our images, the computer is doing a lot of pre-processing before our images pop up on the screen. So we have to use the data that the computer is giving us to help us fix our images. So you're going to look at your EI or DI numbers and then determine how underexposed you are. And that's going to help you to determine how much you need to increase your mass. Now, exposure index numbers are very specific to the manufacturer. So you would have to know the ranges that are acceptable for the machine that you're using and how to play with those. DI is much nicer because it's more universal. So deviation index is basically saying how much did you deviate from perfect. So deviation index is a more universal measurement. So on a deviation index, 0 is perfect. It means you didn't deviate at all. You nailed it, right? If your deviation index number is low, you're underexposed. And if it's positive, you're overexposed. So this is a much easier tool, much friendlier to use because it's universal. So you can apply it to any machine, any portable, any room. And then you kind of know from there, okay, if I'm negative, I'm underexposed. If I'm positive, I'm overexposed, and then decide if it's a repeatable image or not. So with a deviation index, for every -3, you would double your exposure. So if your DI index pops up -3 and you go, oh, yeah, that does look grainy. I can see that. I need to fix it. You would take your mass and double it, and that should get you pretty much to 0. Now, the same applies in the other direction. So if you're +3, you would take your mass and cut it in half, and that should pretty much get you to 0. Okay. So if your DI popped up and it was -6, you'd cut it in half and cut it in half again. So I hope that helps. Now, the second part of the question asked about the quantum noise, how we tell which indicators we use, which is EI and DI. And then the other thing you have to remember to do with digital imaging is to zoom in, okay? Because your pictures pop up so small. So in the days of film, when you took an x-ray on film, it was life size. So when you got a chest x-ray on a piece of film, that was the size of the patient's body, okay? Now you take chest x-ray on a 14 by 17 detector and it pops up and it's this big, right? That is not the size of the patient's body. So you have to remember that pictures are always going to look better when they're really small, right? Just like when you look at them on your phone and you see a little thumbnail, it looks pretty good. And then you open it up and you start zooming in and then you go, oh, yeah, that's not actually a very good picture at all, right? The same thing will happen with your x-rays. So if you're questioning, if you're seeing something on the screen, you need to zoom in, right? Pinch and zoom, okay? Get out the magnifying tool, whatever you got to do, and go in and check. Am I actually seeing quantum noise? Am I seeing motion? Am I seeing an artifact? Because if you're standing back and looking at that tiny little picture on the screen, you're going to miss stuff, okay? So don't forget to do that. But the first thing that you're going to look at is going to be either your EI or DI number. because that's going to tell you how much exposure the detector got. Then from there, you're going to use your eyeballs to go in and actually examine the image and say, okay, the computer's telling me I'm underexposed. Do I actually see quantum model? Do I really need to repeat it? Or is it just a glitch in the math problem over here? And then you can evaluate it properly and go from there. I hope that helps you. Okay. Next question. This comes from Cindy. She says, I have a question about radiosensitivity. I'm trying to fully understand the difference. If a tissue experiences biological damage at low doses, that means it has high radiosensitivity. And if it only shows damage at high doses, it has low radiosensitivity, correct? Yes, you are correct. So high radiosensitivity means the tissue is easily damaged, even at low doses. So it's saying it's very sensitive. And then low radiosensitivity, you're saying that it's not very sensitive. The sensitivity level is low. So tissue is more resistant, okay? So it's only going to show damage at really high doses, right? So you could kind of think of the difference between like glass and metal, right? If I drop a metal bowl on the floor, it's just going to make a loud noise and bounce around. If I drop a glass bowl on the floor, it's probably going to break, right? So one is more sensitive than the other, okay? So this goes back to the law of Bergoni and Tribodeau, which basically says that cells are more radiosensitive when they're more mitotic, which means they're going to divide more rapidly, or they're undifferentiated. So they're immature, they're not specialized, or they have a long mitotic future. So they're going to do a lot of replicating in the future. So things like bone marrow, gonads, lymph glands, these are all going to be very radiosensitive. Muscle cells and nerve cells, not going to be as radiosensitive. Okay. So easy way to remember this, the faster the cell divides and the less specialized it is, the more vulnerable it will be to that radiation damage. So I hope that helps clarify that. Okay. And another question. All right. I'm going to really try not to butcher this name. I think it's Jorgen, but it may be Jorgen. So I apologize if I said it wrong. What is the best approach to studying the skull? It seems like a lot to remember for the registry. You are correct. It is a lot, definitely. And I know that everything above the neck is very scary, mainly because we don't do a lot of head work anymore. You've probably heard a lot of the seasoned techs talk about how back in the day they did skull and facial bones and orbits and all those things all the time. And now we hardly ever do them. A lot of that stuff just goes straight to CT. So things that we don't do and we don't see often do become very scary. So start with the foundation, start with the basics. First thing you want to do, get comfortable with the anatomy. Because if you don't feel comfortable with the anatomy, you're not going to feel comfortable with the actual images. Because then you're not going to understand why you're positioning in a certain way. The whole reason that we have the projections that we do is to show anatomy in a certain way, right? Why do we do this oblique at this degree? And why do we do the lateral with the patient in this position? And why do we do this? Every projection has a reason because we're trying to display that anatomy in a particular way. So first you have to get comfortable with the anatomy. So start with that. The skull has a lot of bones, right, that have all been fused together over time. So it can seem very overwhelming. Let's start with the bigger bones, get comfortable with those, get comfortable with the sutures, right? Get comfortable with the fossas and the foraminas and all the little structures. And then gradually work your way down into the smaller and smaller bones. And then start working on the actual structures of each of those bones. So learning about the different the angles and the fossa and the foramina and all those things. You just keep getting smaller and smaller and smaller as you go. Then when you start talking about positioning, get very comfortable with your positioning lines. So things like your IPL and IOML and AML and all those abbreviations, right? And there's a ton of them. Get really comfortable with those so that you understand what all those letters mean and where those lines are going on the actual skull, okay? Because then when you get into the positioning part and you're seeing, this line is perpendicular and this line is parallel, And you're going to feel more comfortable saying, okay, I can imagine in my head what I'm doing with the skull in that moment because of the lines, right? Then when you start thinking about positioning, think about positions that go together, right? So there are certain projections that we use for the skull. There's certain projections for the facial bones, and there's certain projections for sinuses and mandible and orbits, right? So break them into groups so that those things will seem more related. And then think about the actual projections and what are we trying to see, right? So a lot of the evaluation criteria for a lot of those positions will say things like the petrous ridges are, and then it will say above the orbits, below the orbits, in the lower third of the orbit, right? So we have to think about those landmarks and the things that we'd be looking for when that image pops up, right? We want this to be in profile. We want this to be superimposed. We want this to be elongated. So think about specifically, why are we doing this position and what are we looking for? Because every position has its own purpose. And that should help you to start remembering, oh yeah, if I want the petrous ridges to be in this position, I have to do this with the head, right? Or if I want, this thing to be in profile, then I have to do this with the head. And that will start to make things make a little bit more sense. But if you just go into the textbook and you try to memorize a bunch of numbers and random AML, IOML, it's going to get really confusing. Okay, so you really got to get comfortable with your anatomy, and then get comfortable with your positioning lines, and then get comfortable with, why am I even doing this projection? What is it showing? And then those things should start to actually make some more sense when you realize what the purpose of the exam is. All right, well, thank you guys for being here. Have a great night, and we'll see you on Thursday.